Hello coders! Today we're talking about ICD-10-CM coding for Chapter 12, Disease of Skin and Subcutaneous Tissue. These are our L codes. They run from L00 to L99. Now, the majority of our guidelines here are going to be about pressure ulcer stages and pressure ulcer stage codes. We will also look at the other categories in skin and subcutaneous tissue, and we will look at the pressure ulcers themselves to make sure that we understand what the guidelines are saying. So it starts with our pressure ulcer stages. Codes from category L89, pressure ulcer, identify the site of the pressure ulcer as well as the stage of the ulcer. Okay, so it's a combination code. So if it is a pressure ulcer, we need to know the anatomic site and the stage. The ICD-10-CM classify pressure ulcer stages based on severity, which is designated by stages 1 through 4, unspecified, and unstageable. So we need to know anatomic site and what stage, or they can also use the terms unspecified or unstageable. So let's talk more about what those mean. We assign as many codes from category L89 as needed to identify all the pressure ulcers the patient has if applicable. Some patients will only have one pressure ulcer. Other patients will have multiple pressure ulcers, and so we need to code for each and every pressure ulcer for each and every anatomic site. So what are unstageable pressure ulcers? Assignment of the code for unstageable pressure ulcers, L89, should be based on the clinical documentation. These codes are for pressure ulcers whose stage cannot be clinically determined. So like the ulcers covered by eschar or has been treated with a skin or muscle graft, and pressure ulcers that are documented as deep tissue injury but not documented as due to trauma. These codes should not be confused for codes for the unspecified stage. When there's no documentation regarding the stage of the pressure ulcer, assign the appropriate code for unspecified stage. So unstageable means we can't tell. And we can't tell because of trauma, we can't tell because of a graft, we can't tell because of dead skin, and all of those will always end with the last character being 0. If we don't know, then it's going to be unspecified, and where the last character will end with 9. So that's what we need. We need the provider, or sometimes this is going to be the nurse, who's going to document the anatomic site and the stage. If they use the terms unstageable or unspecified, we need to make sure we're picking out the correct 6th character. So assignment of the pressure ulcer stage code should be guided by clinical documentation of the stage or documentation of terms found in the alphabetic index. We'll look at that in a few minutes. For clinical terms describing the stage that are not found in the alphabetic index and there is no documentation of the stage, the provider should be queried. So if they're not using one of the terms that we can easily identify as a term associated with a stage, we always have to go back and ask them. Now, patient admitted with pressure ulcers documented as healed. There's no code is assigned if the documentation states that the pressure ulcer is completely healed. So once it's healed, we stop coding it. Patients admitted with pressure ulcers documented as healing. So if they're still in process, pressure ulcers described as healing should be assigned the appropriate pressure ulcer stage code based on the documentation in the medical record. If the documentation does not provide information about the stage of the healing pressure ulcer, assign the appropriate code for unspecified stage. If the documentation is unclear as to whether the patient has a current or new pressure ulcer, or if the patient is being treated for a healing pressure ulcer, query that provider. However, for ulcers that were present on admission but healed at the time of discharge, assign the code for the site and stage of the pressure ulcer at the time of admission, because we were treating it. So we need to know if a patient was discharged from the hospital and their pressure ulcer has healed. We still need to document that because we were actively doing wound care during this point of time. So we want to make sure we get paid for that. That needs to go on the billing forms. Now, if the patient is admitted with a pressure ulcer evolving into another stage during the admission, okay, so if a patient is admitted with a pressure ulcer at one stage and progresses to a higher stage, 2 separate codes should be assigned. One code for the site and stage of the ulcer on admission, and a second code for the same ulcer and site and the highest stage reported during that stay. So when it evolves, meaning it goes up, it's not getting better, it's getting worse. Okay, we are going to code from where it started and where it ended, but also the other portion is true. If, let's say, someone goes into the hospital with a stage 4 pressure ulcer and they come out with a stage 1 pressure ulcer, we are also going to code both of those, again, to let the insurance company know that we have been actively treating it, because we want them to know either the pressure ulcer has gotten better or it has gotten worse, and we need to indicate that either way. So that's about our pressure ulcer. So let's look at the codes for a few minutes, then we're going to come back to the non-pressure chronic ulcers. So again, using ICD-10 data, I pulled up our L8-9s, which is our pressure ulcers. Now the L8-9s will go on for pages and pages and pages, because again, each and every anatomic site that can have a pressure ulcer, we need to know if it is, as you can see here, unstageable, stage 1, 2, 3, 4, or unspecified. And we're going to have this for both the unspecified part of the body, so like the unspecified elbow, then we're going to have codes for the right elbow versus the left elbow. And then we're going to continue down. And so again, we can see here when it ends with a 0, it's unstageable. We can't tell because of something that's on top of the pressure ulcer, like a burn, like a graft. Okay, versus 09 is the unspecified stage. Again, it ends with a 9 to let us know that we don't know. Unstageables, we can't tell. Unspecified is we don't know. And so again, we're going to have unspecified part of the back, right upper back, left upper back, right lower back, left lower back, and we're going to continue down. We're going to have codes for the sacral region, so the sacrum coccyx and the tailbone. We're going to see ulcers of the hips, also very, very common. The buttocks as well, another common place. Now, this is something we have to be careful of. Pressure ulcer of continuous sites of back, buttock, and hip. So this is a pressure ulcer that's kind of spreading along all of these areas. This is usually someone who is going to be bedbound, would tend to get something like this. Also, we see pressure ulcers of the ankle, of the heel. We're going to see it of the head, and then of other site, and then of unspecified site. L8-9.9 codes should rarely, if ever, be used because we should know where it is. Even if we don't know or can't tell what stage the actual pressure ulcer is in, we should still be able to identify where it is on the body. So again, these are just in case codes, just in case we need to describe one of these scenarios. Now, I'm going to escape out of this because after we go over our non-pressure ulcer, chronic ulcers, then we are going to come back and look at the L97s. So the non-pressure ulcers start under B. So number 1, patients admitted with a non-pressure ulcer documented as healed. Okay, so again, no code is assigned if the documentation states that the non-pressure ulcer is completely healed. So again, just like our pressure ulcers. However, patients admitted with non-pressure ulcers documented as healing. So non-pressure ulcers described as healing should be assigned the appropriate non-pressure ulcer code based on the documentation in the medical record. If the documentation does not provide information about the severity of the healing of the non-pressure ulcer, assign the appropriate code for unspecified severity. Okay, and we're going to look at these. Again, they have different types of severity, but they're not staged like our pressure ulcers are. Okay, and again, if the documentation is unclear as to whether the patient has a current or new non-pressure ulcer, or if the patient is being treated for a healing non-pressure ulcer, query the provider. Always go back if the documentation is unclear. Now again, for ulcers that were present on admission but healed at the time of discharge, assign the code for the site and severity of the non-pressure ulcer at the time of admission. So again, the guidelines are running the same. Okay, if it's healed, then we don't code it at all because it's healed. If it is healing, we are going to code what's happening right now. If they came in with a pressure ulcer and it healed by the time of admission, we still code what the pressure ulcer was at admission. All right, so if a patient is admitted with a non-pressure ulcer that progresses to another severity level during admission. So if a patient is admitted to an inpatient hospital with a non-pressure ulcer at one severity level and it progresses to a higher severity level, two separate codes should be assigned. One code for the site and severity level of the ulcer on admission, and a second code for the same ulcer site at the highest severity level reported during the stay. So again, the biggest thing we need to know: pressure ulcer, non-pressure ulcer, anatomic site, severity. But let's look at the difference with the L97 codes. So again, the L97 codes, they're using a much more descriptive proponent. Now, stages 1, 2, 3, and 4 have their own descriptions as well. Non-pressure ulcers use these instead, so we need to know: limited breakdown of the skin with a fat layer exposed, necrosis of muscle, necrosis of bone, muscle involvement without evidence of necrosis, bone involvement without evidence of necrosis, other severity, unspecified severity. And again, similar anatomic sites. So we're going to see the thigh, okay, the calf, the ankle, heel and midfoot, other specified parts of the foot, unspecified parts of the foot, unspecified parts of the lower legs. And then again, as we continue down, we get more to our unspecified parts. Now again, we wouldn't want to use an unspecified part of the lower leg unless we have no other information. Otherwise, when they told us it was a non-pressure ulcer of the lower leg. But let's look at how they describe these conditions. So when you're looking up pressure ulcers, what ends up happening is, again, most of the time we're going to know it's a pressure ulcer. They're going to tell us, but what are the other words? So other words that they might use is a bed sore, decubitus ulcer, which is a very common one, a plaster ulcer, a pressure sore, or a pressure area. So how do they describe non-pressure ulcers? Okay, it also includes chronic ulcers of the skin, non-healing ulcers of the skin, non-infected sinus of skin. They might use the term trophic or tropical ulcer, or just an unspecified ulcer of the lower limb. So again, this is what's interesting, is that, you know, again, pressure ulcers are usually because someone is constantly in that position. They're sitting in a chair, or they're laying down. Maybe they're not being turned, or they can't turn as much as they're supposed to. Versus non-pressure ulcers can be caused by a variety of scenarios, including diseases and conditions. So you can have a diabetic who has a pressure ulcer, or a diabetic who has a non-pressure ulcer. So again, how do they describe it? But this is also important. Under the pressure ulcers, up at the top says code first any associated gangrene. So we're going to go back to the I-96 codes for that. versus at the top here, it's going to code for any associated conditions such as gangrene, and here are other causes of non-pressure ulcers. Okay, the atherosclerosis of a lower extremity, fatty plaque buildup in a vessel, chronic venous hypertension, again, our diabetic ulcers, post-phlebitic syndrome, post-thrombotic syndrome, varicose ulcers. So again, different ways of describing the type of ulcer, different terms, different synonyms, but also different code first because of cause versus effect. Okay, so here are some of the main causes of non-pressure ulcers versus pressure ulcers is because of the pressure from the body onto that bone, onto that area of the body. But again, these are not the only codes in this section. So just as a reminder, what else are we going to find within this? So again, the first set is we're going to find our infections of the skin and subcutaneous tissue. So again, these are going to be things that, children can pick up and that we can pick up from the public. We're going to look at bullous disorders. When bullas are very large vesicles, they can be filled with a variety of substances, usually non-infective. Dermatitises and eczemas, which are usually caused by either contact with something, whether physically or ingestion, and then things like eczema is a genetic disorder and something that cannot be caught. We have the papillosquamous disorders. These are going to include things like psoriasis. Remember, squamo is square or square-like, and the papillosquamous disorders, they tend to have like plaque on the top of the skin. We have urticaria and erythema. These are our hives and the rednesses of our skin from a variety of sources. We have a whole series of radiation-related disorders of skin and subcutaneous tissues. So again, this is going to be from things like actual radiation therapy, but also from sun radiation, and another big one that people forget about, tanning beds. We're going to see some disorders of the skin appendages as well, which is going to include things like our hair, our nails. Then we're going to have our intraoperative and post-procedural complications of skin and subcutaneous tissue. And then the other disorders are going to include what we just looked at, pressure ulcer and non-pressure ulcer. It's also going to look like things like vitiligo, the loss of skin pigmentation, other types of skin pigmentation disorders, seborrheic keratoses, acanthosis nigricans. These are all different types of growths. Some of them are non-cancerous, some of them are precancerous. Corns and calluses, the thickening of the skin, other epidermal thickening, keratoderma. So again, remember kerato, that's the keratin that really makes our hair and nails thick. Again, we're going to see things like our pressure ulcers, other atrophic disorders and hypertrophic disorders of the skin, so the loss of skin and the excess growth of skin. We have lupus erythematosus, so this is one of our complications with lupus. This is what tends to lead to what a lot of people think of as the butterfly rash, where on either side of the face, it kind of makes it either side of the butterfly on someone with lupus, and there's other complications that go with it. Different types of vasculitises, and then of course our other disorders, because we've looked at our pressure versus non-pressure ulcers. But keep in mind, we always want to know what's happening to the skin. If you look up skin in this book, it's going to tell you C condition. What's the condition of the skin? And don't be afraid to go and look at an alternative wording for the same condition. The doctor or provider might state it one way, and you might think of it another way. So always keep all of this in mind as you're coding for integumentary diagnosis coding. Have a great day.